Hi, everybody. Great to see you here this evening. My name is Anne Marie Adams, and I'm a faculty member in the Department of Social Studies of Medicine, and it's my pleasure to welcome you to the 46th Osler Lectureship. Before we begin tonight, I'd like to take a moment to thank my SSOM colleagues, Professor Todd Myers and Heike Ferber, who did most of the organization for our event tonight. I'll now turn the podium over to McGill's Vice Principal Health Affairs and Dean of the Faculty of Medicine and Health Sciences, Leslie Fellows, to say a few words of welcome. Then representatives from the Osler Society will introduce our distinguished speaker, and I'll see you again for the Q&A. Leslie.
Thanks, Anne-Marie. That title is too long. I had to develop a sort of acronym to remember it. Welcome, everyone. Bienvenue à tous et à toutes. It's really a pleasure to welcome you to this event, which is a lovely recurring lecture series, or lecture rather, at McGill for a long time. And this amphitheater is the perfect place to hold it. A special welcome to Dr. Gordon Guyatt, our distinguished speaker. I also welcome the members of the Board of Curators of the Osler Library, who are a wonderful group of supporters and providing important guidance to the library. Osler's one of the most famous members of the McGill family, and it's interesting to reflect on his contributions, of course, to medicine and to the way that we still today practice and think about medicine and teach medicine. Not all of his ideas have stood the test of time, but for sure his ideas about the importance of combining a systematic, even scientific approach to understanding disease with a humanistic understanding of the person suffering from an illness is absolutely central to the practice of medicine and how we teach medicine at McGill. And I'm looking around at some of the medical students, recognizing some of you here. I had no idea you guys could look so pulled together. Maybe we're going to bring in a dress code for the... I wanted to make sure I thank all the people who put this together. Let's see. Anne-Marie, Mary Earl, Todd, Heike, Lily, and Nivea, the other student presidents of the Osler Society, who I understand couldn't be here today, but is being replaced by Liam Wilson, a member of the society as well. It's great to have this energy coming from students being involved in this, and working all the way up to people who have been around for a while, and take a real interest in ensuring that Osler's legacy and ideas continue to be thought about and taught about. So that's very nice. I want to particularly acknowledge the Molina Foundation, and Dr. Molina is here, and Pam and Rolando Del Maestro family. Pam and Rolando are also here for the scholarship and the William Osler Medical Student Essay Awards in their names. Those of you who participated in yesterday's activities had a chance to see some of our talented students in action. I thank Dr. Guyatt for taking up this invitation and speaking to us. He's, to me, is a perfect person to invite for this. Really, the balance between evidence-based medicine on average and how to apply it to the individual patient and how we've been navigating that over the last while is, I think, a perfect topic for the Osler lecture. So, thank you very much for coming. And I'll stop talking and invite Lily and Liam to come up to introduce our speaker.
So good evening, everyone. My name's Lily, and I'm a third-year medical student at McGill, and I'm also one of the co-presidents of the McGill Osler Society. We welcome you all to the 46th Osler Lectureship, a collaborative effort by the students of the McGill Osler Society and the Department of Social Studies of Medicine.
Hi, so my name's Liam. I'm a first-year MD PhD student here at McGill, and I'm a member of the McGill Osler Society. So first, I wanted to take this moment to acknowledge that McGill University resides on ancestral lands that have been significant meeting and exchange grounds for indigenous people, including the Haudenosaunee and the Anishinaabe nations. We express our gratitude and acknowledge the diverse indigenous communities whose enduring presence has enriched this territory where people around the world now gather.
Additionally, we want to emphasize that the Osler Lecture offers an opportunity to deeply reflect upon issues of racism and other forms of harm in medical education and practice, contextualize historically, and to envision ways to foster change and healing in our present and in our future. We reaffirm our steadfast commitment to promoting equity, inclusion, and diversity as foundational principles of events named for William Osler. It is our distinct honor to introduce the 46th Osler Lecturer, Dr. Gordon Guyatt.
Dr. Guyatt is a distinguished Canadian physician and a distinguished university professor in the departments of clinical epidemiology and biostatistics and medicine at McMaster University in Hamilton, Ontario. He is widely recognized as a pioneer of evidence-based medicine. In a recent interview with McGill anthropologist Todd Myers, Dr. Guyatt recounts coining the term in the early 1990s, saying that I published a single author paper in 1991, the first time EBM, short for evidence-based medicine, appears in the medical literature. Nobody noticed that one, but in 1992, the JAMA paper established the idea. This landmark Journal of American Medical Association paper from November 1992 was co-authored with John Cairns and David Churchill. In 2015, Dr. Guyatt was inducted into the Canadian Medical Hall of Fame. Dr. Guyatt was born and raised in Hamilton, where he lives today, and has dedicated to addressing medical system dynamics, social justice, political activism, and medical reform that has consistently shaped his medical career.
Dr. Guyatt pursued his Bachelor of Science at the University of Toronto. Subsequently, he earned his medical degree at McMaster University and became a certified general internist. Later, Dr. Guyatt attained a Master of Science in Design, Management, and Evaluation from McMaster University. So, Dr. Guyatt, the floor is now yours.
Thanks very much. Obviously, a particular honor to be here. Named lectureships are always wonderful to be presenting, and to be presenting the Osler Lectureship is a particular honor. So thanks to all those who considered that I would be a good choice to give this. I'm going to talk about how evidence-based medicine has, and for some of you, maybe more raising your curiosity, how it has not changed the world. So, I'm going to start out with conflicts of interest. I'm co-chair of the GRADE working group, and you're going to hear about GRADE. I'm the steering committee of the BMJ Rapid Recommendations, and you're going to hear about the MAGIC Evidence Ecosystem Foundation that's associated with that and that I'm associated with, and I've done a lot of work consulting with UpToDate. So, the world before EBM. If one says, how has EBM changed and not changed the world, it's worth thinking about what the world was like before EBM. The dominant influences on medical decision-making were unsystematic, well, one element was unsystematic observations. And it's been remarked that by the time you are in your second year on the wards, many young doctors will already be talking about, in my experience, something or other happened. Physiologic reasoning was at the center of the way medicine was taught. There was a high respect for content area experts and for precedent, which sometimes went back many, many years, relying on remote content experts. And what is perhaps most striking to the lay public, there was no teaching whatsoever in medical schools before 1990 about how to read and understand the medical literature. There was zero about looking at methods and results, and the reliance was strictly on somebody else's interpretation of the literature. And many lay people are very surprised when they learn that. So, when a clinician was uncertain of what to do and thinking of, should I do A or B, how could that clinician resolve the problem? Well, with the way medicine was before EBM, they could reflect on their own clinical experience. They could reflect on the underlying physiology, or they could go to the literature, either a textbook or a recent article that provides advice, and If it was a primary research article, they would go straight to the discussion and see what the author tells them about the significance and how it affects their practice. Or they could go to a local expert. These were the ways of solving the medical problems that clinicians faced before EBM. And that was a problem. And it was a problem not only for the individual clinician, but for the experts who were providing guidelines or recommendations. And this is something called a cumulative meta-analysis, which describes thrombolytic therapy and whether thrombolytic therapy could reduce mortality in patients who'd undergone myocardial infarction. The 1.0 down the middle means no difference in death rates in patients who did and did not receive thrombolytic therapy. 0.5 represents a 50% reduction in the odds of dying. The blue dots are the point estimates, the best estimates of effect of treatment as the data accumulated, and the lines around it are the 95% confidence intervals, the range of plausible truth. The first randomized trial of thrombolytic therapy, conducted in the late 1950s, had a very small sample size, 23, and as a result, a very, very wide confidence interval. The second trial enrolled not 65 patients, but 42. This is a cumulative meta-analysis adding all the patients in the trials as the trials were completed. And you can see up to 7 trials in less than 2,000 patients, the 95% confidence interval crosses no effect. In other words, the data was still consistent with a harmful effect, an increase in mortality with thrombolytic therapy. But by 10 trials and 2,500 patients, the confidence interval no longer crossed no effect, and we were at the point where we get what have been called significant p-values, making chance an unlikely explanation. Now, we could discuss when the answer was in about the benefits of thrombolytic therapy in reducing death after myocardial infarction, but most of us might probably say by 30 trials and over 6,000 patients, the confidence interval is getting quite narrow. The lower boundary of the confidence interval is a long way from no effect, and we're getting a pretty impressive p-value, suggesting chance cannot explain the results. Did that stop people from doing randomized trials of thrombolytic therapy? No, it did not. Another 40,000 patients were enrolled after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did they need to enroll another 40,000 patients and end up, as you see, with a very, very narrow, unnecessarily narrow confidence interval and a very, very small, unnecessarily small p-value? I believe that the main answer to that reason why they needed to keep doing the trials is on the right side of this slide with textbook and current review recommendations that the experts were making as these data accumulated. Anywhere from calling thrombolytic therapy routine, specific indications, calling it experimental, or not even mentioning it. 2 things about this. If you look at right from 1980 on, wide divergence among the experts. Some calling it routine, some only specific, some calling it experimental, some not mentioning it. And it was a decade before the answer was in, decade after the answer was in, that finally you get the consensus among the experts. And if you talk to the people who were doing the trials, they knew the answer, but they felt to convince the experts to routinely give thrombolytic therapy, we just have to keep doing trial after trial, unnecessarily in the most desirable world. Second example of a similar phenomenon, this is prophylactic lidocaine, an antiarrhythmic agent. We know that after heart attacks, myocardial infarctions, patients are at risk of dying in the first days, particularly of lethal arrhythmias. Lidocaine is a long-established antiarrhythmic agent, and so biologic and physiologic reasoning suggested we give lidocaine and we will prevent these arrhythmic deaths after myocardial infarction. So 45 years ago, when I was in training and rotated through the coronary care unit, every patient who came through the door, I started what we called a lidocaine drip, an intravenous infusion of lidocaine. Was there ever any evidence from randomized trials to support what I was doing? No, there was not. If you look at this cumulative meta-analysis, the point estimates are always on the harm side, always an increase in death with prophylactic lidocaine. Never quite proven that it killed people, but certainly proven that it didn't extend anybody's life. Did this stop the experts from recommending prophylactic lidocaine? No, it did not. The majority, as you see on the right side of the slide, as these data were accumulating, were recommending prophylactic lidocaine, and that's why my attendings were telling me that I should be administering it to my patients. But again, expert disagreement all over the place. In the late 80s, most saying give it, some saying not give it, some not even mentioning it. So here we have the situation before evidence-based medicine. Experts, the experts publishing, the ones who were seen as most creditable, disagreeing, being a decade behind the evidence, or repeatedly making recommendations that contradicted the evidence. Something was seriously amiss. So I should say the final point of this, these stories end in 1990. Something changed in 1990. Experts still make mistakes, but they still disagree, but perhaps not to the extent that you see with these stories. Something happened in 1990 that made this very unfortunate situations less likely. Anybody have any idea what might have happened in around 1990 that changed this? Yes?
The internet?
No, the internet did not. As a matter of fact, if you looked at the internet, I would say most of us think that the internet is a major source of misinformation rather than something you can trust. Okay, I get my first applause. Thank you very much. Okay, so what it was systematic reviews and meta-analyses. Okay, these data that I've just shown you, if physicians had these data available where you see harmful effects, or as you accumulate the randomized trials, they wouldn't have done it. If they had seen meta-analyses that showed this very narrow confidence interval around substantial benefits, they wouldn't have done it. But systematic reviews and meta-analyses were not around, and clinicians did not see them. So systematic reviews and meta-analyses only became prominent in the medical literature after 1990. So my mentor, Dave Sackett, came along, and my last slides were about the experts not knowing how to interpret the evidence. Dave's first idea was, it's a shame that the medical students and young doctors and older doctors have no idea how to interpret the medical literature and that they are not taught at all. So he thought that clinicians should be able to read methods and results of original articles and make inferences, and he called it critical appraisal. And in 1991, he and his colleagues at McMaster University published this first article in a series in the CMAJ that turned out to have a very large influence. And it was how to read clinical journals, why to read them, and how to start reading them critically. So, at the beginning, this critical appraisal that Dave Sackett was advocating was a classroom activity. He was a brilliant guy in a number of ways, but one, he came up with nifty phrases. He started to talk about bringing critical appraisal to the bedside, whereas when you were in the hospital or outpatients, you would recognize a clinical problem and use there for your patient, you would use the literature to solve that problem. So as the clinician, you'd say, do I do A or B? Let's find out what the literature, what the evidence has to say about it. Look for the evidence, ideally find the most credible evidence from randomized trials, and this would trump your physiologic reasoning and your personal experience and what the experts might have been saying if the literature tells you convincingly what to do. For those of us who were trained by Dave Sackett, and I was one, and we took this to heart and started to apply it in our day-to-day care, it felt like a different way of practicing medicine. And people nowadays cannot quite imagine, I don't think, what it was like with the physiologic reasoning and the experience and the expert reliance, and nothing about the evidence specifically. Looking for the evidence and being skeptical when it was not there, because often it wasn't, was felt like a different way of practicing medicine. And in 1990, with this new feeling like this was a new way of practicing medicine, I took over the internal medicine residency program at McMaster University with the mission of teaching this new way of practicing medicine. And I wanted to say to people who were thinking of where to go, come to McMaster to do this new way of practicing medicine. Well, it would be useful to have a name for it. Come to McMaster to do something specific with a name. So I thought, what are we going to call this? My first idea was scientific medicine. And I was introduced to the Department of Medicine as the new residency director. The Department of Medicine at McMaster was filled with basic scientists who, when I said we're going to call this scientific medicine, their reaction was universally outrage. The first person who asked a question as I was being introduced at an evening meeting of the Department of Medicine, his hands were shaking. He was so angry at this because they were the scientists. We clin epi people, my goodness, they were the real scientists. So the reaction was so intense that I thought this scientific medicine, that's not the right name. My second try turned out to be pretty catchy, evidence-based medicine. And as was mentioned in the introduction, 1991, this is the first paper where the term evidence-based medicine appeared in the medical literature. And to give you an idea of just how long ago that was, this is what I looked like at the time this paper was published. So, nobody particularly noticed that, but as was also mentioned in the introduction, what brought the evidence-based medicine to the attention of the world was in the world's largest circulation medical journal, JAMA, in 1992, published a paper where we were not modest. We were somewhat, we put it in people's faces. We said this was a new approach to teaching the practice of medicine. As it turns out, we weren't too far off. It proved ultimately to be a new approach to practicing medicine. In that paper, we said that up to now there had been an excessive emphasis on tradition, physiology, clinical experience, and expert opinion, and we had an alternative. Systematic studies of diagnosis, treatment, and prognosis, differentiating between trustworthy and more trustworthy and less trustworthy evidence. And in this particular paper, which was about teaching the practice of medicine, we said a description of how we taught this new approach. This paper made a gigantic splash and put evidence-based medicine on the map as a new approach to practicing medicine. But I'm not sure how far it would have gone had JAMA not made another decision to publish what we called the User's Guide to the Medical Literature. This was, I've told you about Dave Sackett's series a decade before. This was now becoming a much more practical approach to using the medical literature to solve patient problems. The first paper was published in 1993. By the year 2000, this series had 25 papers in JAMA and became the curriculum for teaching evidence-based medicine in undergraduate and postgraduate medical programs throughout North America and later on throughout the world. So within a decade of that first appearance, evidence-based medicine had become a core curriculum in undergraduate and postgraduate medicine. Happened very quickly, and then became, by 2000, in most places, it was a criterion for accreditation. You had to do it. Wasn't there a decade ago, and suddenly you had to do it as part of accreditation. Now, there are the way I like to characterize evidence-based medicine is 3 key principles. One of those is the hierarchy of evidence, which Dave Sackett suggested. And he suggested a very simple hierarchy. It recognizes that our clinical experience is a source of evidence, although not terribly trustworthy. Basic research can help. Observational studies focusing on patient-important outcomes can help. And randomized trials are at the top of this particular hierarchy. A second principle is the necessity for systematic reviews, which emerges vividly, I think, from those stories about thrombolytic therapy and Lidocaine in myocardial infarction. This gentleman is Ian Chalmers. How many people in this room have heard of the Cochrane collaboration? Okay, everybody's heard of the Cochrane. This guy is the guy who came up with the idea of the Cochrane collaboration and was the engine of really getting it going, and now the 10,000 systematic reviews that are part of the Cochrane collaboration. And the third principle, a somewhat perhaps ironic principle of evidence-based medicine, evidence itself is never sufficient to make clinical decisions. It's always evidence in the context of values and preferences. This guy, Brian Haynes, was one of the people to make the point. Brian was the chair of my clinical epidemiology and biostatistics department for a decade. And he wrote a paper which captures the essential message. Evidence does not make decisions, people do. So I'm going to take you through a study done by another of my colleagues, P.J. Devereux, who did this study some time ago. PJ is now changing the world with respect to the practice of how people manage their patients perioperatively. I'm going to tell you about his study, and I'm going to ask you to participate in the latest edition of this study. I'm going to ask you the questions that PJ asked his participants, and I'm going to ask you in a moment for your answers. So attend carefully. Without treatment, 100 patients with atrial fibrillation, which increases the likelihood of having a stroke, will suffer 12 strokes, 6 major and 6 minor. Anticoagulation, thinning of the blood, would decrease the strokes in 100 patients from 12 to 4, 8 fewer strokes, 4 major and 4 minor. And the question is, question you're going to have to answer, how many serious gastrointestinal bleeds would you tolerate in 100 patients and still use anticoagulants to decrease the likelihood of stroke? Now, Dr. Devereux asked his questions to both physicians and patients. He had to explain to patients what it was to have a stroke and what it is to have a bleed, and here's how he did it. I'm going to give you a minute to read through and see what it means to have a minor stroke and what it means to have a major stroke. So that's major and minor strokes. Dr. Devereux also had to explain what it is to have a serious gastrointestinal bleed. This is his description of what it is to have a serious gastrointestinal bleed. Okay? So, we return to the question. Without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor. Anticoagulation would prevent 8 of these people from having strokes, goes from 12 in 100 to 4, prevents 4 major and 4 minor strokes. And the question in these 100 people, how many serious gastrointestinal bleeds would you accept and still be willing to use as a patient or recommend to your patients as a clinician anticoagulants? Any questions about what I've asked you? Okay. How many would accept 5 or fewer bleeds? If it's more than 5 bleeds, no thank you, no anticoagulation. How many would accept 5 or fewer? At least a couple of, 3 people, I think, 4 people, something like that. Who would accept up to 10 bleeds? No more than 10. You'd accept more than 5, but no more than 10. How many 6 to 10? Don't see too many takers there, so a couple. 11 to 15. You'd go over 10, but not over 15. How many? Okay, a few people. How many would go up to 20 bleeds? You'd accept up to 20 bleeds. Anybody? Anybody over 20? Okay. Not everyone has participated, but perhaps those who have are maybe not too different a distribution from what I've observed. This is Dr. Devereux's results, which I have asked this question in medical audiences many, many, many times and have replicated Dr. Devereux's results with the physicians. Look at the physicians. A flat distribution. Some ready to accept very few bleeds, some intermediate, some a lot. First message, extreme variability in values and preferences. This is a value and preference issue. How much do we value preventing bleeding? How much do we value preventing strokes? And the physicians have very wide range. But look at the patients. 2/3 of the patients said, I'll accept 22 bleeds. Why 22? Seems like an odd number. Dr. Devereux, when he designed his study, was thinking like a physician. He said the patients wouldn't choose more than 22. Had he given them the chance, they would have. Okay? The patients, on average, are much more stroke averse than are the clinicians. Much less bleeding averse and much more stroke averse than are the clinicians. So that's one message. If you want to listen, if you want to make your practice consistent with patient values and preferences, you better know something about the patient values and preferences. And in this case, they're stroke averse. But not everybody. There are a few people who are more like the clinicians, more bleeding averse. They're at the other end. And that's the other message of this. If you really want to get it right, better to use average values and patient values and preferences than the physicians. But if you really want to get it right, you have to get the individual patient values and preferences into your decision. That then, the third principle of evidence-based medicine, evidence never tells you what to do. It's always evidence in the context of values and preferences. So everything's going along fine, except that we got something fundamentally wrong. And what we got fundamentally wrong, it was turned out to be completely naive to think that physicians could actually read the methods and results of original articles and apply them to their practice. At the end of 7 years of running the internal medicine residency program, where I was trying to achieve that goal, I concluded it was not possible. And in the year 2000, we published in the BMJ a statement to the effect that learning critical appraisal is not the best way to achieve evidence-based practice. Few will have adequate training, and you need more than medical school and residency. You need something more, quite a bit more intensive of that to really do it. And those, even if they did have the training, people would not have the time. The alternative at the time was pre-appraised systematic reviews that I've alluded to earlier. More recently, a considerably more preferable alternative to that is trustworthy clinical practice guidelines. 20 years after we published it in the BMJ, the EBM teaching community worldwide still does not quite get it and still tries to engineer their teaching to get clinicians to do the critical appraisal, meaning reading the methods and results. It's not going to happen. So we published another article in 2020 basically making the same point. So around 2000 then, we're realizing that the initial focus on teaching clinicians to actually read methods and results and understand them, that's not going to work. So the EBM leadership in the EBM community basically shifted to deciding what we want to supply to clinicians is trustworthy guidelines from people who have with expertise in processing the literature. This guy, Andy Oxman, came up with the idea is we need a really good structured system for looking at the certainty or quality of the evidence, anywhere from high to low quality evidence, and a process of considering values and preferences as we need to, as we move from evidence to recommendations. First, the group called itself GRADE, published first, started to meet in 1999. 2004, published the first article about the GRADE approach in the BMJ. This is the little cartoon that went along with it. I interpret this as the prior systems of looking at the literature where the three people who were having problems getting across and the guy marching across was the guy using GRADE. Turns out this was pretty successful. Over 110 organizations worldwide have adopted and are using GRADE, including the World Health Organization, leading American organizations, American Thoracic Society and American College of Physicians, the Cochrane collaboration. How many people in this room look after patients? How many of those who look after patients use UpToDate? Okay, I think just about everybody who's looked after patients uses UpToDate. Wherever I go in the world, all over the world, if I'm in front of an academic audience, the majority of clinicians are using UpToDate. The impact of UpToDate and its use is really quite extraordinary. There are over 10,000 graded recommendations in UpToDate. All right, so this GRADE approach, 2004 first publication, 2008 six-part series in the BMJ for guideline users, subsequently in the Journal of Clinical Epidemiology, a whole series of papers for the people who do the systematic reviews and guidelines. Originally therapy, turns out the approach works well for diagnostic accuracy, impact, and prognosis as well. And here is GRADE's approach to rating the certainty of evidence and the strength of recommendations. 4 categories of confidence or certainty of evidence: high, moderate, low, and very low. Randomized trials start high, but they may not stay high. I presented earlier Dave Sackett's very simple hierarchy of evidence. This is much more sophisticated. Risk of bias problems, lack of concealment, lack of blinding, loss to follow-up, lowers our confidence. Inconsistent results across studies. If the patient before, the trials don't match the patients before you. I practice as a secondary care, hospital-based internist. Many of my patients nowadays are over 90. I try to base my practice on randomized trials, but I hesitate. I have less certainty when I do that in my patients over 90 because very few of them have participated in the randomized trials. The trials in the younger people provide indirect evidence for the older people. Imprecision of results, small sample sizes, wide confidence intervals, and publication bias. So a whole bunch of things that can lower the certainty of evidence from randomized trials. And there are certain interventions like replacement of the hips for hip osteoarthritis. I've had 2 of them myself. Epinephrine and anaphylactic shock, insulin and diabetic ketoacidosis. Bunch, not a huge number, where we don't need randomized trials because the effects are very large. We are confident in the benefits of our treatments without randomized trials when effects are very large. So that is the new, much more sophisticated hierarchy of evidence that GRADE came up with. GRADE also says how you're on a guideline panel, how do you get from evidence to recommendations? And it identifies the fact that the closer the balance between desirable and undesirable effects, the more likely you are going to have to make a weak rather than a strong recommendation. The lower the quality of the evidence, you're not going to be as confident. The variability and uncertainty about values and preferences, you're not going to be as confident, and you may want to consider cost. Additional criteria that GRADE has suggested more recently, the acceptability, feasibility of an intervention, and its impact on equity. We like this. So GRADE says in the end, a panel will make a strong recommendation or a weak or conditional recommendation. Strong recommendation means that the panel believes that everybody or almost everybody will make the same choice. A weak recommendation when the choice, for all the reasons we've said, particularly a close balance between desirable and undesirable outcomes and variability in values and preferences, will make a weak recommendation. That has implications for interacting with the patients. When I go around the world talking to medical audiences, there is one question I ask them where I always get the same answer. I can be anywhere in the world and I always get the same answer. And that question is, do you have enough time to spend with your patients to do a really good job with every patient? And everybody in every audience says, no, I don't, which means we have to ration our time as clinicians. And GRADE gives a good approach to rationing time, because if it's a strong recommendation and the panel has got it right, no need for a sophisticated shared decision-making exercise, because if the guideline panel got it right, if you did it, everybody or almost everybody would make the same choice. That patient, you can say, here's what I think you should do, and here's why. Whereas with a weak recommendation, if the panel has got it right, different patients will make different choices depending on their values and preferences. And then you need to do shared decision-making if you're going to get it right for the individual. Decision aids are, shared decision-making is hard. Decision aids can help you. I'll show you briefly a decision aid in a bit. And a strong recommendation, you might not be worth the effort. Everybody is going to make the same choice. A weak you would. So guidelines have to use average values and preferences. Should you do it? Should you not do it? Okay? But at the point of care, ideally we would like to tailor it to the individual patient. This is Victor Montori, a professor of medicine at Mayo Clinic, who has done the world's leading work in decision aids. But the goal of decision aids are to ensure decisions are consistent with individual patient values and preferences. Victor's a endocrinologist, diabetes specialist. He's developed this decision aid for his patients with diabetes. He tells them there are various ways these medications differ. Their effect on weight, their effect on hypoglycemia, how much they will lower your blood sugar, their daily routine, daily sugar testing, and cost. And he says, which one would you like to know about first? What do you think the most popular first choice is? Weight change. Right, weight change. Weight change is the most popular first choice. Victor tells me that over 40% of the people like to go there first. And they may then go to their daily routine. They may then go to cost. And ultimately, they may go to all 6, except they never do. They usually make their choices on 4 at the most, mostly 3, even 2. So this is an incredibly efficient approach to shared decision-making because each patient gets the information that that patient needs and doesn't need to know about everything. And we have here an example of Victor doing it.
So yes, I agree. We need to make sure your sugars are better controlled. So that means we need a new medication. So which aspect of your next diabetes medication do you want to discuss first?
Weight change.
Weight change? I'll let you review that.
Okay. So this is the one that I'm on.
Yeah, you're already on metformin.
Well, this one looks good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn about next?
I'd say the daily routine.
Sure.
Okay, so-
Yeah.
Oh, so this is an injectable.
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject the needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No,
Okay.
no. I'd much rather just pills. So this is okay. Well then, so this sulfonylurea is.
That's the next
So
best
this
one
one-
for you in terms of the weight, huh?
Yeah, yeah.
Well, that's a daily pill, so that you can start with just one pill a day.
Yep, and just 30 minutes beforehand.
Yeah, usually 30 minutes before breakfast. Would that be okay?
Yeah, yeah.
Okay, well, the other thing to consider is that sometimes they can give you low blood sugar, so we're going to ask you to monitor a little more often than you're doing right now, but otherwise that will be okay. If you were to change your mind after you go home, I'll give you this pamphlet. It has the same thing as the cards, so as you're using the tablet, if you find that it's not what you were expecting, review this again and give me a call and we can discuss it again.
Okay.
All right, thank you.
So, shared decision-making, evidence-based shared decision-making in 90 seconds. Doesn't always go that smoothly, but the approach really is, I think, an impressive innovation in shared decision-making. And these cards are a type of decision aid. So you can think of what happened scientifically in evidence-based medicine. So first of all, we started out with clinicians. If you go back to 1990, the systematic reviews were just starting to appear. Look at randomized trials, and we had standards of more trustworthy and less trustworthy randomized trials. Then systematic reviews came along, and the the stories after myocardial infarction tell you how important that those were. And we then had standards for what makes a good systematic review, trustworthy systematic review, and what doesn't. And then it's been superseded by guidelines, which is what clinicians mostly rely on. And we've seen here, and I've told you about elsewhere, the incredible impact of UpToDate, which has this profusion of guidelines, which I've mentioned. I'm very conflicted. I've been doing, my job with UpToDate is to try and get them to be as evidence-based as possible, which I've been doing for 15 years, so I have to believe they're not doing too bad a job at it. Guideline quality, if you go back 20 years, the guidelines mainly fit the acronym of GOBSAT. GOBSAT stands for good old boys sitting around the table. So what we've moved is from GOBSAT guidelines to trustworthy guidelines. So I believe the last individual I want to introduce you to, Per van Veek. It's another, Per van Veek has been very interested in guidelines and trustworthy guidelines and how to make guidelines accessible, nicely accessible for physicians. And he said, what do we need to take these from GOBSAT or even trustworthy guidelines and make them really accessible and useful to clinicians? And what he decided he needed was magic. Magic stands for making grade the irresistible choice. So, big part of magic, and you'll see it kind of does feel magical to some of our non-tech folk like me, is an electronic platform that allows you to present the guidelines so that people can get them in a layered format on their iPhones and other devices. They get integrated into the electronic medical record. It facilitates their adaptation, and it allows you to provide decision aids. So, a note about EBM in the time of COVID. My take is, in many ways, it was the culmination of EBM showing just how wonderful an impact EBM can make. Unprecedented rapid profusion of evidence, randomized trials, what are called platform trials, an innovative way of doing it, international ones with names like Recovery, Solidarity, REMAP, CAP. Unprecedented cooperation among the trialists, rapid sharing of data. I work very closely with the World Health Organization and their COVID guidelines, and people have been nice about sharing with the WHO. And living, in other words, very rapidly updated systematic reviews, innovation in the last decade, network systematic reviews and network meta-analysis allows the simultaneous comparison of a whole bunch of drugs, in this case drugs for COVID, and then these living network meta-analysis informing the guidelines. The World Health Organization is now collaborating with MAGIC and the BMJ so that the WHO COVID recommendations appear simultaneously in the WHO and in the BMJ, a source that many clinicians might go to rather than the WHO if they are in high-income countries. So very rapid production of evidence, very rapid production of top-level systematic reviews, very rapid introduction in guidelines. And these is an example of one of the COVID guidelines appearing in the BMJ and WHO, and here's what the MAGIC app can do. So here are the WHO guidelines, and we're going to go to nirmatrelvir ritonavir, which is the most effective for non-severe COVID, which most COVID now is non-severe. And the recommendation will tell you for patients with non-severe COVID at higher risk of hospitalization, a strong recommendation. And for some clinicians, that may be enough. Below it are some key guidance, the most important of which that these drugs interact with other drugs, so you have to be careful depending on what else the patient is receiving. But you can get more information if you want. You can go to the research evidence, and if you go to the research evidence, you have what is called summary of findings tables, which for each outcome tells you the relative effect of treatment, the absolute effect of treatment, the certainty of the evidence, and a narrative statement such as the drug probably reduces hospitalization. And if you want, you remember grades criteria for going from evidence to recommendations. You can go and find out what the panel thought the benefits and harms were, the certainty of the evidence, what the value, what the panel inferred about patient values and preferences, acceptability and feasibility. You can find out about their justification. You can go to practical information, route, doses, and duration. Some clinicians may just say, oh, they told us what to do. It's a strong recommendation. I'll give this to my patient. I'll tell you the patient this is what you should do. But I need to know some practical information. So that's the only other thing in this whole set of information. Or you may be the sort of physician who wants to do shared decision making, and you would like a decision aid, and the decision aid that we make now follows Victor's principles. You don't try to tell the patient everything. You try to tell the patient what that patient wants to know. So here's all the things that the patient might want to know, and the patient, with guidance from the clinician, might want to say, well, what about admission to hospital? And it turns out there's your probability of being admitted to hospital goes down by 30 in 1,000 or 3% if you take the ritonavir nirmatrelvir. Some patients may have difficulty with the numbers. So, So, here is a visual depiction of 1,000 patients. And in the 1,000 patients, the one in the orange and the black are the total number who would be hospitalized if they don't take the nirmatrelvir ritonavir. The ones in orange represent the 30 fewer in 1,000 or 3% who would not be hospitalized if they take nirmatrelvir, ritonavir, who would otherwise. And the physician can use that to explain it to the patient. So, where I would say how evidence-based medicine has changed and not changed the world. Here is an incomplete change in the world. To do the shared decision-making, you have to understand the magnitude of the benefits and harms. Otherwise, if you don't understand that, how can you explain it to the patient? As it turns out, we did an international study where we said what ways of presenting the evidence are most understandable and appealing to physicians. We weren't surprised that risk difference was the top, relative risk, and so on. However, even the ones that were most appealing to physicians, they only got the magnitude of the effect right 50% of the time. And physicians don't have to know the critical appraisal, looking at the medical methods and results to do good evidence-based medicine. They do need to understand the magnitude of effects. And this made it clear to me we're not there yet. So, how has EBM changed the world? Much less reliance on experience, physiology, and tradition. Pillar of health sciences education throughout the world. Best evidence, is a wide acceptance that the best evidence from systematic review should guide practice, and this sophisticated, great approach to coming to the certainty of the evidence. Trustworthy guidelines, huge influence on practice, and we now have standards for trustworthiness rooted in the great approach. How has EBM not changed the world, or at least not fully or not yet? One thing, we got it wrong. We thought all the clinicians were going to be reading the methods and results. It will never happen. Trustworthy guidelines are the solution to that problem. As we move to guidelines, we need to make them living, which they haven't been up to now. In other words, rapidly updated, and we have to get the optimal presentation, which I think I've shown to you with the Magic app about that electronic presentation, where the clinicians can look as little as to what they want or as much as they want. And we need to get the third principle of evidence-based medicine, the ironic third principle, perhaps least well understood. Evidence never makes decisions by itself. It's evidence in the context of values and preferences. And clinicians have to understand the magnitude of the effect to do the shared decision-making that is necessary if you're going to make the right choice for each individual patient. And I want to end with a little bit of self-promotion. If you want to find out the latest in evidence-based medicine and you're ready to go to what has been ashamedly renamed X rather than Twitter, you can find it there. So there is what I want, my idea of how evidence-based medicine has changed and not changed the world. I'd be delighted to take questions and comments.
So please ask your question. The only trick is that we have a wireless mic that you must use for the recording, and Liam kindly offered to run it up to you. Yes.
We can also, if you're running around too much, getting tired, I could also repeat the question.
Yes.
Hi, my question is, one of the concerns I've noticed in medical pedagogy with the popularization of EBM is that basic physiology and understandings of the basic science of human behavior and physiology seems to also be decreasing in terms of the way that we think about pathology. And historically, that's also led, it's obviously led to a lot of innovative research once one really digs into the physiology. Is that a concern you share, or do you think that that's not really...
I hope that it wouldn't discourage people from going into basic science research. And if you believe that they need to be exposed enough to physiology early on to encourage them to ultimately end up as basic science researchers, then that would be an issue. Otherwise, I'm not too concerned because over and over again, we've seen that physiologic reasoning does a good job of giving us candidates for what to study in randomized trials. It does a really poor job of accurately and consistently predicting effects on patient-important outcomes. So I'm not worried about the de-emphasis. In fact, I'd rather like the de-emphasis as in medical education, unless one believes that it's going to discourage people for careers in basic science, because we still need people, we still need basic science to produce the interventions, candidate interventions that we can then test in randomized trials.
Where here in this evidence lie the problem of tacit knowledge and how we deal with this?
Tacit knowledge?
Tacit knowledge, non-structured knowledge that is hard to structure and yet we use it daily.
Give me an example of tacit knowledge so I understand what you're talking about.
Well, tacit knowledge is said that there's a knowledge that you know, but you don't know how.
Okay, as physicians, give me an example of tacit knowledge.
I failed right now.
Okay, all right.
But it doesn't.
By just looking at the patient with lots of experience,
Okay, good. Okay. So
there's also a problem that tacit knowledge is not in the guidance because that's only structured knowledge.
well, I have to, before I'm going to worry about that, I have to understand the tacit knowledge that we use. Okay. So yes, so there's what we call pattern recognition. Okay, and physicians definitely rely on diagnosis and pattern recognition. So that's a nice example. But as it turns out, you can, one example that we use where physicians make a diagnosis in 5 seconds is somebody appears, oh, I've got this pain and some itchiness, this rash appeared, and it's in a line right around here. Okay, the only thing that does that is herpes zoster. Okay, so that's great pattern recognition. But the first time you see it as a student, your mentor or clinician to say, look, it follows the dermatome. These things always come in dermatomal distributions. You see something in a line like this or this part of the face, that is herpes zoster. Okay, that training facilitates pattern recognition. So yes, it might end up as tacit knowledge, but that doesn't mean you can't communicate the underlying basis of that tacit knowledge. At least in the example of pattern recognition, you clearly can.
Obviously, you've gone to a certain point, but medicine is clearly. Obviously, evidence-based medicine has gotten to a certain point, but we're moving to precision-based medicine now. You know, where, for example, if you have a brain tumor, we're doing all your genetics. We know which part of, in certain tumors anyway, what is going to be actually effective in that particular area. And we have not, evidence that every time we use a particular drug, it's going to work. So we're basically moving to the point of doing that type of activity. But then you have a problem.
I'm going to stop you, and you tell me the problem afterwards, okay? Because I'd like to say that's not new. Evidence-based medicine from the beginning has been looking at subgroups. So you say, okay, here's your population. Does the treatment differ in the men versus the women, in the old versus the young, in the people with severe disease and the people with less disease? And you find out, okay, it does differ. Then you're going to apply the treatment effect in men to the men and the treatment effect in the women to women. All that's happened now is we've got another way of looking at subgroups. We've got genetic markers, we've got tumor markers, we've got various things. It's no different from separating the men and the women. It's separating the people with the marker and no marker and treating them according to the effect in men and women or treating them the effect in marker or no marker. It is no different from what we've been doing with EBM from the beginning.
I guess my second question, you have all this knowledge, and then you tell it to the patient, and the patient says, I don't want to do that.
Well, if you I'll follow that up and then you can follow again. The skilled clinician will say, why is that? Help me understand. The clinician thinks, if I understand the situation you're depicting, the clinician thinks it's the right thing for the patient to do X, and the patient says, no, thank you. Is that what we're talking about? Yes. Okay. Then you need to find out why. And it may be one possibility. We say that values and preferences must be applied by fully informed patients who understand the evidence. Okay? So one possibility is that you've done a poor job of explaining the evidence and the patient really doesn't understand the benefits and harms. Well, the inquiry with the patient, and if that's the case, then you better review again, use a decision aid, make sure the patient does understand the benefits and harms. What's another possibility? Another possibility is that the patient has somehow developed a belief system, like some of the belief systems people developed about COVID vaccines, and they are completely you can talk to them about the evidence as long as you like. They are not going to believe you. They have another belief about the benefits and harms. Their decision is perfectly rational given their belief about the evidence and harms. That may be another thing that comes out of the inquiry with the patient in the situation you're talking about. A third may be you find out that for whatever reason, the patient's values and preferences are very different from most people's, and that makes them. Extreme example, you recommend a blood transfusion and find out your patient is a Jehovah's Witness, and that is why they are declining it. They have a particular belief system, or a particular, no, I shouldn't say belief system, they have a particular set of values and preferences that make the decision that's right for most people and that you think might be right for the patient. You find out that it's wrong for the patient because of their particular values and preferences. So the bottom line is the skilled clinician will, finding a patient that's doing something that seems irrational, will explore the possibilities that I've just raised to find out what is the explanation and proceed accordingly. And you had another part that you were about to ask.
I just, when you're dealing with this and you have a patient, who has that particular belief, clearly that takes a lot of skill sets, like a experience. Well, let me put it this way: if you've seen that particular problem on a number of occasions, you have developed those skill sets that you just talked about. But how does an individual who hasn't had that experience,
Well, doesn't this tell us some perhaps deficiency in medical education at the moment? Maybe we should be paying more attention to teaching people those kind of skills because they are teachable, just as I said with the pattern recognition. They are teachable, and your question to me, and you're pointing out that people may not have the skills, say, well, if we believe this is basic to being a good physician, which I think it is, maybe we'd better pay more attention to teaching it than we do at the moment.
Okay, perfect. Hi, I just had a question basically about the type of stroke study that you did versus should we give blood thinners or not to them, and bleeding versus severe stroke risk. How does medical literacy play into how we interview these patients? Are we assuming that they have a baseline of medical knowledge and that they can appropriately interpret the leaflets that we're giving them that weigh causes and not and stuff like that? How could we kind of improve such screening tactics for a wider population of patients who might not understand the severity of a severe stroke to its fullest extent, or the severity of a stomach bleed versus something else? So just medical literacy in general, how does it play into this?
Well, great point. So another thing about the skilled evidence-based practitioner who acknowledges the importance of understanding shared decision-making and values and preferences has to make sure the patient understands. So one of the things that such a clinician will do is to say, Can you tell me what I've been through it, tell me now what your understanding of a stroke is, what your understanding of a gastrointestinal bleed is. And sometimes things may take more time. You may have to say, go away and think about it and come and review it again a second time. So it's a matter of making the effort to find out what the patient really does understand. And if you need to go at it again, you go at it again.
There are some areas of medicine like pediatrics and rare diseases where there's very little evidence, and there's unlikely to be evidence in some conditions that are so uncommon that you're just not going to have trials. What is your suggested approach to making decisions together with the patient, using their values and preferences, in those situations where there's no strong evidence, and you're never going to have the magic approach? How would you suggest?
Well, so to start with, very often in such situations as you're talking about, you have very little direct evidence, but you may have indirect evidence. So if you take the pediatric situation, fortunately there's a lot fewer sick kids than sick adults, and very often you will have randomized trials in adults, and then you have to make a decision of how to apply it. You don't say there's no evidence. There may not be randomized trials in kids, but EBM acknowledges indirect evidence. It says, here are the randomized trials and results. How might they differ or not differ with the kids? And it isn't in rare disease, just in rare diseases or pediatric populations. Lots of things in the adult medicine I do, there's only very low quality evidence. Whenever there's only very low quality evidence, the decision becomes critically value and preference sensitive because we have different attitudes. So you have a situation, well, here's an example. Early COVID, okay? So early COVID, we have a whole bunch of treatments that are being suggested. They're suggesting this, that, very low quality evidence about anything, okay? So it's a sick patient, and you have you go to the patient and you say, well, here's something we could give you. It has adverse effects, which we're pretty certain about its adverse effects, but we have very little idea of whether it benefits or not. It may or it may not. One set of values and preferences says, doctor, if it might help me, I'm ready to put up with the risk. I feel very sick, or my prognosis may not be so great. I will try it. Another patient says, doctor, you mean you're telling me you have very little idea whether there'll be any good or not for this, and you know there's harms. Why would I take it? So people have very different attitudes toward risk aversion, and the job of the evidence-based clinician is to communicate what the most likely benefits and harms are and our certainty in those, and that's clearly going to affect how people make the decisions. So there's a parody of evidence-based medicine, which is patient comes in, oh, I got a real problem here. Doctor, please help me. Doctor turns to the computer. Sorry, no randomized trials, can't help you, okay? That is the farthest thing from evidence-based medicine. What evidence-based medicine does is comes up, even when it's low or very low quality evidence, our best estimates of the harms and the benefits, acknowledges the uncertainty and communicates that situation, both the most likely estimates, but also the uncertainty around it, and then incorporates that patient's values and preferences and attitudes about uncertainty in making the decision. I see lots of hands here. That's nice. Where's the mic? Okay, whoever's nearest the mic wins at the moment. Okay, so here.
Okay, hi. Thank you very much for your
welcome.
talk. I found it very useful. I am a social scientist. I am not a trained physician. So my question relates to the transfer of evidence-based medicine and randomized clinical trials into the social sciences, specifically economics. And as you probably know, the 2019 Nobel Prize for Economics was awarded to two MIT economists who say they base their understanding of the uses and the effectivity of international aid in poor countries to their randomized clinical trials.
Yes.
So I don't perfectly understand how the transfer takes place. For instance, how does joint decision-making factor in for the economists? And I'm wondering if you could explain that to me.
Well, probably not, because I'm not an economist, but I can give some, I mean, the fundamental thing that you pointed out, there may be areas like education. We have all these people with education theories. Who knows what actually works? We could sort it out with randomized trials. There are areas, not every area of economics, but as you've just pointed out, there are areas of economics where you can do randomized trials, and people got a Nobel Prize for doing them. It's hard I find it a little difficult to picture the decision-making situations, but it would be the same thing. Understand the evidence. It may be that the decision makers are at a policy level rather than an individual level in terms of implementing various strategies at a population level. That may be more of what happens in economics, but it's also what happens in public health. Public health is the same thing about implementing decisions at population levels. And I guess all I could say is I think the same principles would apply. A good understanding of the upsides and downsides of the alternative choices, an understanding of the quality or certainty of the evidence, and a recognition that with that evidence, one set of values and preferences will make one decision, and another set of values and preferences will make another decision. You want a situation right at the moment that occurs to me, how you deal with gender dysphoria, okay? So low or very low quality evidence for most of it, and clearly radically different values and preferences would lead to different choices. Anyway, bottom line is I would have thought, I'm not an economist, but I would have thought that application of the same principles would work very nicely.
Yeah, I think we'll just take one more question, if that's okay.
Whatever you say.
I know we don't have much time. I'll be very quick. I'm a master's student in experimental surgery, and I come from an engineering background, so a little different to the people here. A lot of my research is all AI-focused, machine learning, so my question kind of points to the future. Lately, a lot of clinicians are relying and trying to leverage the black box notion of AI solving problems that we can't understand. And in relation to evidence-based medicine, it seems the big emphasis is truly understanding the cause and effect relationships and being able to explain these in simple terms to our patients, etc. So where do you see evidence-based medicine going in the future, leveraging and taking into account this new movement that doesn't seem to be changing towards AI and solving problems and answering unanswered questions with it?
Well, you have to tell me what sort of, so at the moment, I'm involved in developing a checklist for studies that look at the accuracy of AI chatbots in telling us of summarizing the evidence and making recommendations, and see how, and the way you would do that is see how it corresponds. But I think you're talking about, can you give me an example of the sort of AI application you're talking about?
Clinical, you have anthropometric data that you input into a model, and you have a treatment plan that comes out on the other side.
Sorry, but there's a great, the answer to that is you do a randomized trial of getting the machine to do it or getting people to do it ordinarily. And if the outcomes are better with the machine than people doing it with the alternative, great, you'll use the machine. And if, as I might anticipate, you'll get some disappointments and the machine doesn't do better, but the worst thing you can do is to assume the machine is going to do better without testing it out. So I would say the machine applications that we hope will improve patient outcomes, we got to test using the same methods of randomized trials to see whether they really do improve patient important outcomes.
Okay. Please join me in thanking Dr. Guyatt.